सर प्लीज वॉइस नहीं आ रहा है.
The program is yet to start. We will start in a minute. So, am I audible?
Yes, yes.
Yes, sir, please.
Thanks. So, very good afternoon to you all on this wonderful afternoon. So, I'd like to welcome you all on this wonderful program. And we have a reason to gather today. And today is the World Thalassemia Day. Actually, it is yesterday. We are just commemorating this World Thalassemia Day today. So, we welcome you on behalf of CRC Davangere. It's a Composite Regional Center for skill development, rehabilitation, and empowerment of persons with disabilities. And we are located in Davangere, Karnataka. So we are under the administrative control of NIPED, National Institute for the Empowerment of Persons with Intellectual Disabilities, Secunderabad, under the Ministry Department of Empowerment of Persons with Disabilities and Ministry of Social Justice and Empowerment, Government of India. So our organization, we have started functioning since February 2017. And we have the services, we have three objectives, primary objectives like skill development, rehabilitation, and empowerment of all 21 types of disabilities as per RPWD Act 2016. So this thalassemia is a chronic blood disorder. It has been recently included as per RPWD Act in the one of the 21 types of disabilities. And we have all the services here, including the we have training programs, long-term training programs in our CRC and diploma level special education courses in both domains. One is intellectual and developmental disability and hearing impairment. So these two domains we have the courses in our CRC Davangere. So we have to observe these, to commemorate this World Thalassemia Day, and we have a renowned person, Dr. J.S. Arora, as a speaker, guest speaker today. And welcome you, sir, for our program. And before going to the lecture, so I would like to invite our director, Dr. Uma Sankar Mogandi, sir, and to deliver the keynote address about this program. Sir, now the screen is yours, sir. You can take over.
Namaskar. So nice to have you, Dr. J.S. Arora, sir, for our informative program, and hearty welcome to all the delegates who are attending this particular webinar. It's on occasion of World Thalassemia Day, and the theme is Be Aware, Share, and Care. And it is in collaboration with National Thalassemia Welfare Society. We have the General Secretary, Dr. J.S. Arora, sir. He is one of the renowned experts in this field. And I would like to thank the patron of our this webinar, Sri Major B.V. Ramkumar, sir, who is the director of officiating director of NIPED Secunderabad. That is our administrative controlling office. And CRC Davangere, we have been taking a lot of initiative for a lot of webinars, CRE programs, and I appreciate efforts of Dr. Tamarai Selvan, who is the lecturer of physiotherapy at CRC Davangere, for taking this initiative. And along with the coordinators, Dr. Niraj Misra, Dr. Ganvel, and our entire team of CRC Davangere, who is quite proactive. And I appreciate and I appeal all the participants to whenever you get time, you can join in various academic programs we organize. And you know, thalassemia is one inherited blood disorder due to the genetic mutation, which is moving from parent to the child, and due to the obviously hemoglobin, oxygen transfer content in the body decreases due to that. And we have Dr. J.S. Arora, who is going to share his experience related to it, and that related to lack of oxygen leads to slow growth and pale skin, yellow skin, and how it can be managed. Obviously, when oxygen is the main thing which drives all of us, and so we are waiting to hear from our renowned speaker, Dr. J. Arora sir, and once again I appreciate Arora sir for joining us and all participants. And let us have one very educative and informative session. Namaskar.
Thank you, sir. Thanks for your keynote address. And next, straight away, we'll go to the lecture. And so, actually, last week only, we contacted Dr. J. Arora sir. We just contacted through mail. Immediately, the next day, sir responded positively. And sir showed his willingness to take the lecture. And we thank you once again, sir, on behalf of CRC Davangere. And let me have a 1 minute to introduce about the sir's achievements in this particular field, in the area of thalassemia. So, sir is as our director sir said, sir is a General Secretary of National Thalassemia Welfare Society and also the Federation of Indian Thalassemics. And sir is a member of ethical committee in various organizations like the premier organization like IIT Delhi, and IECHR University College of Medical Sciences Delhi, and Chacha Nehru Bal Chikitsalaya Government of Delhi, and ITS Dental College Hospital and Research Center Greater Noida. And sir is a member of State Blood Transfusion Council Government of Delhi. And sir is a founder member of Indian Alliance of Patient Groups and founding trustee of Genomics and Public Health Foundation. And formerly sir is a coordinator of Thalassemic Cell Government of Delhi and member of Advisory Committee, DDU Hospital Government of Delhi, and member Ethics Committee, LHMC and Associate Hospitals, New Delhi. So the list goes on. And sir is a author of Florilegium of Thalassemia in both English and Hindi editions, and also sir is a co-author of the chapter in PG textbook of pediatrics. And sir has got his lifetime service award from PHO member chambers of Indian Association of Pediatrics and the NCPDEP Emphasis Universal Design Awards in 2018. And sir is a member of WHO Advisory Group Patient for Patient Safety Program. And so as a sort of, we have a shortage of time. And so now I welcome Dr. J.S. Arora sir to deliver the lecture, the awareness lecture on this wonderful evening. Sir, now the screen is yours. You can take forth.
Thank you, Dr. Thamarai Selvan, for your nice introduction and inviting me to this world to commemorate World Blood Thalassemia Day. I think this is the topic which is very close to me. And I'd like to share, you must be knowing it, CRC Lucknow also organized this webinar on this. And there I was a speaker just 2 hours back, 1 to 2 p.m. So nice of, I think, CRC Lucknow and now CRC Davangere that they are organizing a webinar on thalassemia. This is so nice.
Yes, it's our pleasure.
I like to thank patron Dr. B.V. Ramkumar, Director NIEPID, and Director Dr. Uma Shankar Mohanty, who is the Director CRC Davangere. And I'm also thankful Dr. Neeraj Mishra and Dr. Namal. I can't pronounce that name, please. I'm sorry. So I'd like to share now my slides. I think if all others can mute, that will be better so that we can understand. Please request others to be muted.
Yes, sir, visible, sir.
Okay. Thank you once again. Thank you much for inviting me. And to start with, I'll say that the word thalassemia, how it comes, thalassemia, that is the nomenclature. See, the first it was diagnosed among the people who were living around the Mediterranean Sea. So thalas means sea and anemia means less blood. So it was called thalassemia. And since it was first diagnosed around the Mediterranean countries, so also known as Mediterranean anemia. And again, Cooley's and Lee diagnosed first time in 1925. So it's also known as Cooley's anemia. So it has 3 names: thalassemia, Mediterranean anemia, and Cooley's anemia. Thalassemia is a type of severe anemia, which cannot be cured by any type of medication. In this, body is not able to make enough hemoglobin. Either there is inadequate formation of hemoglobin or defective formation of hemoglobin. See, life of normal red blood cells is 120 days, but in thalassemia, they die much early, around 15 to 20 days. So that leads to severe anemia. It is caused either by a genetic mutation or a deletion in a certain key genes. And since thalassemia carriers are normal, so it is passed on from parents to children throughout the families without anybody knowing about it. If we talk of genetically, see, hemoglobin is made of 2 alpha and 2 beta chains along with the iron molecule. If alpha chains are less, it is alpha thalassemia. If beta chains are defective, it is beta thalassemia. So in India, since alpha thalassemia is not very common or it's very mild, so whenever we talk about thalassemia, it is automatically understood as beta thalassemia. There are 3 types of beta thalassemia. One is thalassemia minor, trait, or carrier. We have different genes which decide characters of body, height, weight, color, complexion. You can say eyes blue, black, brown. You can say hairs are curly, straight. All these characters are because of the genes only. If pair of gene which forms the blood is normal, the person is absolutely normal. If one of the genes is abnormal, it is called thalassemia trait or carrier. But they are absolutely normal and healthy, do not require any treatment. Thalassemia major is a condition where both the genes are defective. The child is normal at the time of birth, hale and hearty, but by 3 months to around say 6 months, 1 year, up to 2 years, child becomes pale, loss of appetite, retarded growth, delayed milestones. Is the sitting, standing, talking, all milestones are delayed. And if you don't treat or don't diagnose, is this craniofacial deformities there because of this swelling of the facial bones and other skeletal deformities. His abdomen is protruded because of enlarged liver and spleen. And if you still don't diagnose or don't treat, they die at the age of 5 years, by 5 years. There is another condition which is in between the two, that is called thalassemia intermedia. In this case, it can be diagnosed anytime, say from 3 years afterwards to 30 years. I have seen the thalassemia intermedia being diagnosed even after marriage or even after having a child. So mostly they maintain hemoglobin around 7 to 8 grams without blood transfusions. And usually they require blood transfusions only during infections, puberty, or pregnancy. So thalassemia major is a miserable condition. I told you that they become pale, lethargic, not grow well, and 90 to 95% diagnosed within first 2 years of life. And as I also told you, they cannot make enough hemoglobin and there is no medicine to cure it. So the only option left is repeated blood transfusions every 2 to 4 weeks. When child is small, say up to 1 to 5 years, it requires around 1 unit of blood every month. 5 to 6, 10 years, around 2 units every month. 10 to 15 years, 3 units every month. And when child grows old to grow adult, then he or she will require 2 units every 2 weeks, or say 4 units every month. And since with blood transfusion, extra iron goes inside the body. I'll tell you later on, he will require repeated injections and to take out extra iron, for hospital visits, for blood transfusion, investigations, iron chelation, I told you. And the cost of therapy is rupees 50,000 to 2 lakh per year. Pure, but it is only possible if you have HLA matching is not easily available. It is only 25 to 30% in real brother sister, 1 to 2% in parents, and only 1 in 1 million in the general public. And in spite of having a HLA match donor, it is very costly. It costs around 50 lakhs to 30 lakhs. It is very risky because at the time of the operation, we kill the defense system of the patient. So patient is prone to high infections, severe infections, and that may create many problems. So it is not feasible in all thalassemias. And we have to care of this cardiac, liver, endocrine complications arising out of this blood transfusion or iron overload. Gene therapy is a new upcoming option available, but it is still in the research tool and research mode. And even if it comes after say 5-10 years, we don't know, but cost may be 4-5 crores, which is not affordable by any Indian patient. And psychosocial support is very much required for these patients, because at the time of diagnosis, the family is broken. They think they have made some sin, some bigger mistake, and that God has given the punishment, and they don't know what to do, from where to get blood, medicine, all these things. Where are the hospitals? So at that time, they come to us, and we give them, we make them aware of the disease, is complications, treatment, all give them all offer, and that they require psychosocial report. So complications of thalassemia because of anemia, there is breathlessness on insertion, loss of appetite, malnutrition. Social stigma is very important. See, if you go to school, the teacher may think you can't do normal work. They may not give you heavy work. They don't allow to play, and even at family, or you can say near neighborhood, they may think they may not catch by touching or by playing with them, so by sitting with them. So that stigma is there, and because of the inadequate blood transfusion, at times their liver and spleen enlarges, that increases their abdomen, swollen abdomen, and that also increases the blood destruction of the blood cells. The only treatment is the blood transfusion, but there is always scarcity of blood transfusion centers. You don't get even a transfusion centers to get the blood. You have to travel 100 to 500 miles. And transfusion reactions are very common. Infections under B, C, HIV, and the patient has to go for repeatedly for hospital for injection, infections, investigations, and blood transfusion. And because of iron overload, which they get due to blood transfusion, I'll tell you later on, there is a growth retardation, delayed or missed puberty, fertility is another issue, endocrine complication, bone disease, their bone becomes brittle, osteopenia, osteoporosis, and if it deposits the heart and liver, heart failure, liver failure, and ultimately short life. So chelation therapy, they're giving this medicine to take out extra iron. You have to give lifelong, painful, costly. And this, because all of these problems, they have to be absent from the school, college, or workplace. And even for the parents, they have to miss their business or the job. And there is a loss of education and income. If you don't treat or don't diagnose, the child dies between 1 to 5 years. If you give only blood and don't take out extra iron from the body, the life is 8 to 18 years. If you give partial blood transfusion, because these people require blood transfusion to keep hemoglobin more than 10 grams. If you keep hemoglobin around 6, 7, or 8 grams and don't give extra additional medicine adequately to take out extra iron, the life is 15 to 30 years. But one thing is very good. If you treat them well, you give adequate, safe blood and adequate chelation to take out extra iron from the body, the life is as normal as it should have been without thalassemia. Now we have many thalassemics who got full treatment. They are doctor, engineer, professor around the age of 45, 50 years. Some are married, have normal children as well. So you can imagine that how the difference creates the treatment protocol. What is the world scenario of thalassemia? See, they are diagnosed very early. Diagnostic facilities are easily available. Blood is safe blood. Even though in India, the blood is tested for hepatitis B, C, HIV, malaria, and syphilis, but still these people get infection. In Western world, the technology is very advanced, and their chances of having hepatitis B, C, and HIV is much reduced than India. Treatment there is free, borne by either by the employer or the insurance company or by the government. Thalassemics are well educated, gainfully employed, enjoying happy married life. Even grandparents, they become grandparents and living beyond 5th decade of life. I know a thalassemia major patient who is around 60, 65 years of age. While in India, the diagnostic facilities are only in major towns and cities. The patients are not diagnosed in smaller cities. I'll leave aside what you talk of the villages. Patients have to travel 100 to 500 kilometers for proper advice. So even for blood transfusion, even today, say in 2022, we get patients from Bihar and UP especially to take transfusion to Delhi, and same is happening with the other bigger cities. From all different parts of Maharashtra, people go to Mumbai, and same way in the other states as well. Except in selected government hospitals, the family bears the cost of the treatment. Very few are educated because many times the family takes the patient out. They say you can't work, you are tired. Ultimately, they think he is going to die, and they take the patient out of the schools. And they are not very few who are educated, and still rare who get the job opportunity because there is no job or this reservation in even RPW at 2016. Marriage prospects are very low, and very few are married, and very few thalassemia major has crossed fourth decade of life. So why leukodetection? I'm speaking why on this, because these patients require only RBCs. Their only RBCs are defective. They don't require whole blood. These days, the whole blood is divided into RBCs and plasma and the platelets, and whitelets are other thrown. But when they are given blood, they are given packed RBCs. But still, some white cells goes inside the packed cells, and they cause reactions. To avoid the reactions, we require leukoreduction, leukocyte filters. If it is done at the blood bank level, that's very good. But if it is not done the blood bank level, then we have to give bedside filters, which is attached along with the blood bag while giving transfusion. And sometimes they still develop reactions, and then we give wash cells. But even at that time, they require leukocyte filters. Splenomegaly, I told you earlier, if the thalassemia major patients are not adequately transfused, they require transfusion to keep hemoglobin level more than 10 gram pre-transfusion. At 10 gram, we give blood, enough blood to make it to go to 14 gram. Every week, 1 gram drops, where the average becomes 12 gram, so that they can grow normally. But at some places, because of the shortage of blood, ignorance of doctors or patients, or distance between the patient's residence and the transfusion centers, and the adequate blood is not given, so their spleen enlarges. That creates problem, and sometimes it enlarges so much it fills whole abdomen, and patient cannot take adequate food. It depresses the stomach, and that causes malnutrition. And sometimes that spleen, this starts killing normal cells. See, the function of the spleen is to scavenge abnormal cells, abnormal white cells, red cells, etc. But if it becomes too large, it destroys even normal cells. So that further increases the blood requirement. Increased blood requirement also increase the chance of having transfusion-transmitted infections like hepatitis B, C, and HIV. And if TLC, DLC platelet are low, then it is called hypersplenism. Then there is no option left but to take out extra this spleen out of the body. Spleen is a very important organ of the body. It prevents some infections, specifically pneumonia, meningitis, etc. So if at all it has to be taken out, it is delayed till 5 years of age. And these three vaccinations, pneumococcal, meningitis, and Hib vaccines, are given at least 2 to 4 weeks prior to the operation. And after the operation, they have to take lifelong antibiotic, preferably penicillin. If it doesn't suit, then they will give some extra other medicines. And after splenectomy, their platelets rise, so then we have to give aspirin tablet, and we have to give broad spectrum antibiotics whenever they get any infection. And see, and this is an emergency. But unfortunately, this facility is not available at all hospitals, and wherever they are available in government setup, the patient has to wait 6 months to 1 year. And as you will have noticed that after spleen enlarges, they require more frequent blood. That means every 3-4 days or every week. And if their splenectomy is delayed by another 6 months to 1 year, you can't imagine you can want a child to live. And the private cost is 1 lakh to 1,50,000 in private setup, and the most of the patient cannot afford these private splenectomy operation. Iron overload. See, our RBCs are made of primarily protein and iron. Then after 120 days, they are broken. They are divided into iron and the protein. In normal person, the iron is reutilized to form the blood, but in thalassemia major patients, since blood forming organ, that is bone marrow, is not working, so that iron becomes extra. The body doesn't have any mechanism to take out extra iron, because iron is an important organ for the body. So this we have to take it extra iron. 1 unit of blood contains 200 to 250 milligram iron, and a child who takes 2 units of blood every month will get 6 gram per year, or 15 to 16 milligram per day. However, in normal circumstances, we absorb just 1 milligram iron from our food, and excrete 1 milligram iron from the stool. So you can imagine how increase this iron goes inside the body. And those who are not transfused adequately, or thalassemia intermedia, they absorb plenty of iron from their food. So that iron becomes extra in the body. So extra iron causes abdominal discomfort, lethargy, weakness, fatigue, pigmentation of the skin. Skin become dark. The child looks much darker than the family. Liver fibrosis that may start even as early as 2 years after transfusion. Liver cirrhosis by the age of 10 years if the child has already also got hepatitis B or C infection. Joint pains, cardiac problems, and heart failure by the age of 50 years. If it deposits in the thyroid, it causes hypothyroidism. In parathyroid,
Sorry to interrupt, sir. I think you are muted, sir. Hello? By mistake. Doctor sir, sorry to hello? Hello, sorry for the interruption, sir. And you are muted.
सर आपकी साउंड नहीं आ रही है सर.
Yes, sir. Presentation is okay, sir. Only the audio is muted. Now it's okay.
Sorry, शुरू से नहीं आया.
इससे पहले था सर, अभी सर अभी ब्रेक हुआ है.
अभी ब्रेक हुआ है ना?
अभी ब्रेक हुआ है.
Yes, sir.
शुरू से
आयरन के यहाँ से
ओके ओके ठीक है. सॉरी आई थॉट स्टार्टिंग से या तो फिर मैं ठीक है. ओके थैंक यू. I'll repeat the 3 slides. So if that because of iron load, there is abdominal discomfort, lethargy, weakness, fatigue, skin becomes more darker, the child becomes more darker from the family. Liver fibrosis at 2 years, liver cirrhosis by 10 years if child gets hepatitis B or C, joint pains, heart failure, and by the age of 15 years. If it was
sorry, sir. Could you make it full screen, sir?
So,
just press F5.
Yes.
Okay, sir. Okay.
If it was parathyroid, it causes hypoparathyroidism. Pancreas causes diabetes. Pituitary it starts at as early as 2 years of age. That leads to dwarfism, short stature. If it deposits gonads, it causes hypogonadism and delayed or missed puberty and infertility. There are 3 drugs available in the market world over. One is Desferal injection, other is Calfor in India, and the third is Defroxylox. I'll give most tests on Desferal. See, this drug is not orally absorbed. It is only in the injection form. It is given through injection, but not less like tetanus B complex. It once you give, within 5 minutes, it comes out of the body. So it has to be given very slowly with a special infusion pump. This is, you can see, attached to the body of the patient. A syringe is attached with the pump, and it slowly pushes this medicine in the body, take out extra iron. So the slow it is given, the better it is. So it is given around 8 to 16 hours every day. And the cost of the pump is around 50,000 to 35,000 to 50,000. And the medicine cost is 200 to 800 per day. When child is taking 1 unit of blood, he requires 1 injection, and the cost is around 200 or so. When child takes 2 injections per day, 2 units per month, then requires 2 injections per day. When child takes 4 units per month and requires 4 injections per day, so that becomes around 800 per day. I'll show you the real story of a thalassemia patient who is 30 years old, and she has already taken 840 units of blood, 16,800 injections of desferal. She has taken 72,000 hours of her life. She had needle in her body and already spent 33,60,000 just on one desferal injection. And that she could do it only because her father was a government employee and she was getting CGHS benefit. So nobody can afford this for treatment. We expect her to cross 60, maybe 70, 80 or so, but let us count it up to 60 years. And she will require another 1,000 units of blood till 60 years, another 20,000 of injections. That means 1.2 lakh hours of needle in her body, and around 40 lakh rupees only for desferal therapy. This is an important slide. Usually it is for the patient, but it is for you as well. See, this is a one patient, A and B. Both patients have serum ferritin. Ferritin is a blood test by which we come to know what is the iron level. As we know blood level by hemoglobin, so we come to know iron level by ferritin. So two patients, A and B, both had at the age of 3 years, serum ferritin less than 2,000. At that time, A patient started full treatment, all iron chelating agents, whatever he could tolerate, and the B patient did not start it. At 9 years of age, B was having a short stature. At 12 years, he had developed diabetes, and 15 years, he developed cardiac problem. At that time, he realized that he should take treatment. He started treatment by the age of 24 years. And both the patients had same serum ferritin, less than 2,000, but the difference was patient A was absolutely normal, no complication, while the patient B had diabetes and cardiac problems, along with even in spite of low ferritin. So you can imagine the importance of regular and continuous therapy since beginning. I told you that the bone marrow transplantation, or it is also known as stem cell transplantation, for permanent cure. And if the child is small, say less than 6-7 years or so old, and well maintained, and you have a HLA match, 100% match donor available, then the success rate is 90%. 5% rejection means disease comes back, and 5% back. And this may happen at even the best center and the best doctor. But if child is not maintained good, the survival becomes less, success becomes less. 81% say here, 58%, and mortality also rises in class 2 with some complications, 15%, 19%, and adults the mortality is up to 35%. So looking after all these complications, the only way out is prevention. So this first is very important, that how thalassemia is caused. It is only from parents to children. We have different genes. I told you, if one gene is affected, it is called thalassemia carrier. If husband and wife both are thalassemia carrier, every child is, when it is born, it takes one gene from one parent, one gene from other parent. If child takes both normal gene, child is normal, absolutely normal, better than parent. If child takes one normal, one abnormal gene, child is just like parents, thalassemia carrier, doesn't require any treatment. But if unluckily child takes both abnormal gene, child is thalassemia major, who will require regular blood transfusion and iron chelation. But this is for all pregnancy. It is just like for tossing a coin, head and tail. Every time you get same, or in a pregnancy, boy or girl, 50% chance every time. So same way, it is 25% chance every time. You can't say first child is thalassemia major, then second child cannot be major. So you have to check your thalassemia carrier affected fetus in every pregnancy if couple is thalassemia carrier. So this is where the thalassemia is more frequently found. There is a malaria belt starting from African countries to Middle East, then Pakistan, India to Myanmar, Thailand, Singapore to Maldives and Indonesia. So this is a belt where malaria is very common. There is a hypothesis that once you had this thalassemia in you, especially thalassemia major, there are less chance of having this death from malaria. See, you know malaria is two types, malaria vivax and falciparum. Vivax is easily cured by chloroquine tablets, and most people died with falciparum because it is a cerebral malaria. It calls cerebral malaria. So it has a protection against cerebral malaria, but everything has good and bad thing as well. So after gene, this concept was married. Now we are having thalassemia major. So 7% world population is having thalassemia and other hemopathies. Other means that is HBD, E, C, sickle cell anemia. So all these combined are known as thalassemia syndrome or hemopathies. 400 million heterozygous. That means thalassemia carriers are there. Around 3 lakh to 4 lakh babies are born with thalassemia major. You can say severe hemopathies. That can be combination of two hemopathies as well. It may be this thalassemia and sickle as well. India, Thailand, Indonesia have 50% thalassemia carrier. So they have 50% thalassemia major as well. So as like diabetic capital, India is also a thalassemia capital of the world. If you talk of India, in India it is 4% people, that 5 crore Indians are thalassemia carrier. And as per ICMR, 1 out of 18 in thalassemia in Delhi is a thalassemia carrier, and 10,000 to 12,000 thalassemia major are born every year, and 200 new added every year in Delhi. Prevalence is very high in some communities, Punjabis, Sindhis, Gujaratis, and Bengalis, but it doesn't mean it is not there in other areas. Now we are seeing very frequently in South India, which we did not find earlier. We have in this this Kerala, Tamil Nadu, Andhra, this Karnataka, very high incidences over there. I was there recently in Hyderabad. There was a conference, and it's a high prevalence over there as well. And one thalassemia major is born every 45 minutes. That means the moment I finish this lecture, there is another thalassemia major in India. So I have given a picture of Amitabh Bachchan. Why? Amitabh Bachchan is 6 feet 2 inches tall. He's 80 years, and I think the whole around 160 people sitting over in the webinar, he is more active or most active than all of us. If a person like Amitabh Bachchan, he's a carrier. If he can be thalassemia carrier, why you and I cannot be a thalassemia carrier? So first of all, everyone must understand he or she can be a thalassemia carrier in spite of having a normal body structure. Body structure doesn't define you whether you're a carrier or not a carrier. So thalassemia awareness program and screening in worldwide. In Italy, it is mandatory to screen every pregnant woman. In Iran, 1997, they started screening and genetic counseling of our at the time of marriage. In even Saudi Arabia, they have in 2006 started this mandatory screening of 8 diseases at prenatal stage, including HIV, sickle cell, cystic fibrosis, and thalassemia, and 4 others are there. Greek, the carrier rate is 10%. Still, no thalassemia major born after 1990, or say 1 or 2 may be born. At Palestine, you see daily you see a bombing between Israel and Palestine. Even then, they are having a prenatal test is mandatory. So they are doing in spite of all these odds. Pakistan still shows a documentary film on international flights. Taiwan, though carrier rate is very low, 1.55, 1.1%, still they have national screening program since 1993. Maldives, there is still national screening program. US, UK have newborn screening for sickle cell and thalassemia screening for pregnant women. Singapore, they have national prenatal screening since 1997 and 0 birth of thalassemia major. This is again a success story at Cyprus, Sardinia, Greek, Italy. A Cyprus started thalassemia screening program in 1974. In 1984, yes, you can hear, fine. It's audible.
Yes, sir, you're audible, sir. You can continue, sir.
So by 1984, they could reduce to almost 0, and same way Italy and Greek as well. But the very good aspect of the control program in Cyprus was the most important, besides government, the most important role was played by the priest of the church. They will not be giving any this marriage ceremony without you showing a thalassemia carrier status. I think, I pray, I wish, and if even in India as well, if the pundits who perform the marriages or who you can say arrange for the muhurat, janam kulli, all these things, if whatever they do, let them do it. At least they should say 2 words for us as well. They can just say, this our Janam Kundi cannot tell you whether you are thalassemia carrier or not, and who will be your partner. So please go for thalassemia screening as well, besides matching a Janam Kundi or Janam Patri. In India, we have a different thalassemia carrier status, say 1 to 17%. If you see in South India, 1 to 3%. In North India, around 3 to 10%. In Gujarat, also 3 to 17%. It's more common in some communities. Sindhis, Punjabis in northern India. Bhanushali, Kuchli, Luhanas, Gujarat. Mahars and Kohlis and Agris from Maharashtra. Govada and Lingayat in Karnataka. So, by looking at all these facts, there is a need for prevention. As I already told you, it is inherited blood disorder. It's not from any infection or wrong food taking. Repeated blood transfusion, frequent hospital visits, daily injections, lifelong costly treatment, and there is a limitation of permanent cure. And you know, if the government has to spend over 1,800 crores to treat 1.5 lakh thalassemia children who require regular blood transfusion, and it's a big burden for the community as well. And 40% voluntary blood donation is used by thalassemics. If we save just one thalassemia major child, we'll be saving around 1,500 units by her age of say 50 years, and over 1 crore for treatment. So you can save a lot of blood that can be used for other things like surgeries and postpartum hemorrhage. Ignorance is very highly prevalent in general public, even in the medical professional, and they just know thalassemia is blood disorder, what to do, how to diagnose. Many people still don't know it, and it is a preventable, so it should be prevented. Awareness can be created at various platforms. See, social workers, RW Pradhans, local Pradhans, politicians, RS Samaj, Sindh Samaj, Jain, Agarwal, Sikh leaders, whatever may be there, they can be roped in to create awareness in their community or in their area. Teaching institutes like schools and colleges are very most disciplined and organized. That's the best place to create awareness. Nowadays, we have corporates, MNCs, BPOs, where around, say, 500 to 5,000 persons are there within one office or one building. So we can arrange thalassemia awareness lectures over there, and we have been doing that since long. Social media is again a strong tool. Small group meetings, promotional activities like seminars, conference. We are all done 10 conferences, national, various seminars, workshops, etc. And use of mass media to sensitize the public. That's a government job, because no individual society can do a mass media campaign on its own. How to screen and who should be screened? That is very important. The first and foremost, the best place is that the family members of thalassemia major patient, especially siblings, relatives, because they have very high carrier rate. And the second, the best option is all pregnant women attending thalassemia antenatal clinic at first step or first visit should be screened, because at that time they are highly responsive. They are agreed to do anything for their child, and so that we can, and that is the time when we can prevent immediately a thalassemia major child. So they should be screened. There should be a mandatory thalassemia screening program by the government of India. Population screening we have been doing. The government have an anemia screening program, and they should include thalassemia along with anemia screening, because then most of the thalassemia carrier can be cash. Cascade screening, once you screen a thalassemia carrier, then you can test the partners, the siblings, uncles, aunts, all those things, and there you will get the highest screening status in those family members, because siblings have 1 in 2, uncle and aunt 1 in 4, and cousins 1 in 8 risk of being a thalassemia carrier. So the message should be very clear. Carrier state has no disadvantage. They are absolutely normal and healthy. That is the reason wherever we go, we show the example of Amitabh Bachchan. We know many others as well, but Amitabh Bachchan has publicly admitted. So that's why we tell everybody Amitabh Bachchan is a thalassemia carrier. And the risk is only and only when both partners are carrier, and once it is thalassemia major patient, it is fatal, it is costly, it is traumatic treatment, and the curable treatment is not easily available, limited. And fetal diagnosis, that is, we can prevent. So when we can prevent, why we should not go for
Sorry,
thalassemia?
hello? Sorry to
Yes.
interfere, sir. Sir, actually, your presentation missing, sir.
Which missing?
Yes, yes, sir. Someone presented, I think, in between.
Is it still?
Yes, sir. Just wait, sir. Just a moment.
It's
Yes, yes, sir. You just stop presenting and present it again, sir. Then it will come.
stop. Okay.
Click stop presenting and present it again.
From which slide you want me to there?
Just no, sir. Just no, it left.
Okay, okay. Fine.
Yes, sir.
This is the best way you can prevent, and that is to screen every pregnant woman on first visit. If she tests positive, go for the husband testing. If husband is not a carrier, then no action required. If husband is a carrier, go for prenatal diagnosis at 11 to 13 weeks of pregnancy. Fetus
Sorry,
is
sir.
tested.
Sorry to interfere, sir. Sir,
Yes.
still it's not visible, sir. Your
Not
screen.
visible. Is clear.
A kind request to participants, please avoid screen sharing. That's why these kind of disturbances are happening. Please note down. Do not share your screen.
It's okay.
Yes, sir. Yes, it's coming, sir. Yeah.
See, every pregnant woman should be screened in the early pregnancy. The first time when she visits any gynecologist for antenatal checkup and test her for the thalassemia carrier status. If she is a thalassemia carrier, ask the husband for the thalassemia carrier status. If the husband is not a carrier, no action required. If husband is a carrier, go for prenatal diagnosis. We can check the fetus from 11 to 13 weeks of pregnancy. Even if she turns up later pregnancy, we can go up to 16 to 18 weeks. And if the child is normal, go normal or carrier, continue the pregnancy. If the child is major, then she has the option to terminate pregnancy. I think everyone will go for the termination. How to screen? See, I have, though it is for the doctors, but it is important for you as well. See, you must have gone, everyone must have gone CBC testing many times in his or her lifetime, because this is the first test which we do for anything, any infection, anemia, fever, cough, cold, whatever may be, liver, spleen, whatever we do CBC in addition to other tests. So usually even doctors miss. They just look into hemoglobin level, TLC, DLC, and platelet or ESR. They also don't look into MCH and MC values. And you can also look into it if your MCH is less than 27, MCV is less than 80. You yourself can ask your pathologist, laboratory, or doctor to check yourself for thalassemia carrier status. And there is a simple test, that is HB, HPLC. And if HbA2 is more than 3.5%, a person is a thalassemia carrier. Here I like to say that anemia is not a criteria to know the thalassemia carrier status. See, it is true that around 2/3 people of thalassemia carrier are anemic, but one-third are not. So if we see only anemic patients, then we'll miss at least 33% who are not anemic but may be a thalassemia carrier. So what our society or role of society is there? Psychological support, I told you earlier, and awareness up to the patients and caregivers, engage them, empowerment, telling the facilities available to treatment and the facilities available under RPWB Act 2016. Education by printing bulletins, meetings, conferences. We organize blood donation camps, thalassemia clinics, and create new thalassemia centers so that they can have blood transfusion facilities at the nearest their residence. At the time of when there is shortage of medicines in the government sector, we provide medicine to some free or subsidy, give assistance in getting disability certificate, create public awareness, license the corporate to increase facilities or to support the treatment even for the bone marrow transplantation. And since that treatment very traumatic, so we also do recreation activities for them. What are the socio-economic challenges of person with thalassemia? So there are some repetitions. As you know, repeated blood transfusion and survival is very low. Repeated pricks, investigations, and blood transfusion, repeated infections, transfusion transmitted infections like hepatitis B, C, HIV, repeated hospital visits, travel 100 to 500 kilometers for treatment, or even sometimes for consultation, loss of work, education, employment, business, and treatments very costly, not affordable by most of the families. But here I like to stress that the government, most of the government policies are for BPL. The BPL people, I think, those who earn only less than 1 lakh in annum, which is very few, while their cost of the treatment and other things are very high. So here the government should think of that removing the BPL tag for the persons with disabilities for passing on benefits to them. Social stigma is a big issue, and sometimes they don't get recognition in the public and for the family and the parents specifically. So the life expectancy always hovers their mind. So now coming to RPW Act 2016, say what does it mean to thalassemics? In 1995, when first act was passed, it was not there. There were only 7 disabilities were there. In 1996, since then, I have been this crusading for this, including of thalassemia, hemophilia, and sickle cell anemia in the list of disabilities. And 2016 we got it, but still we have still not got it the job reservation, which is still in their mind, in the back of our mind. We're not happy for this one issue. It is again a discrimination in a particular act which is formed for indiscrimination, and it is a discrimination within the act. So that is something the thalassemics are not happy. And but still there are many benefits available for the benchmark disabilities. The one important benefit we got is earlier when our patients had to take employment, even they get employment on their credibility, their education, their knowledge, but they were refused due to medical unfit. And I'd like to remind you one very famous case that was Sukhsoit Singh. He was a high double MA, MBA. He cleared his civil service examination, but he was not given this job in civil services. So twice he was refused because of thalassemia. He was declared unfit, both Safdarjung and RML Hospital. Then we approached the Prime Minister at that time, Dr. Manmohan Singh, and after his intervention, he was given the job. So that was a very difficult for us, but certainly now, and even at that time, when those who were employed, they have not told these employers that they are thalassemics. For the simple fear, once the employer will come to know that they are thalassemics, they will be turned out, they will be fired. So at least under this RPW Act, we have some safety that they cannot be declared unfit because of thalassemia. So education, yes, they have benefited access to free education till 18 years. And the most important is reservation in higher education. That is very good for thalassemics because thalassemics are otherwise very intelligent. Maybe having some problems with the physical, but they are very intelligent. So they can crack any, you can say, exam. So that's why our many patients are now in medical. I still remember when the new act was passed, I was there to get admission for 3 thalassemics in Delhi University, and in many cases I'll show you later on. Yes, there is a provision for aids and appliances, medicine, diagnosis services, and corrective surgery free of cost. Loan at concessional rates, including that of microcredit. Insurance, though there is still insurance rehabilitation, but we are finding it difficult. Not even a single thalassemics have got life insurance or medical insurance. Here we want the intervention of the government of India that they should give a clear instruction to insurance companies to give insurance, life insurance as well as medical insurance to blood disorder. I don't know about the other disabilities, but blood disorders, they are not getting it. So their thalassemia, sickle cell anemia, and anemia and hemophilia, they should be given life insurance and medical insurance without any extra premium. And yes, there is a provision or a special provision for person with disabilities with high sport, which is available for thalassemics as well. So these are the guidelines in the RPW Act in 2016 for how to apply for a certificate, and it is a form 5 is there. Sorry, form 4 is there, and they have to be submitted with the proof of residence and 2 recent passport size photographs, Aadhaar card, Aadhaar number, and this is good that no other proof of residence is required if we have the Aadhaar card. They can apply to any medical authority or the notified district competent authority, and the best is where they are taking treatment. And if the patient is minor, less than 18 years, because they can get it even after 6 months of age. So the parents or guardian has to apply. The very good thing that is there in the act, that is the authority has to provide certificate within 1 month, and if they see the documents not adequate and he is not eligible, then they have to refuse it with giving the reasons within 1 month of the date of the application. Age criteria, I told you, they can get even after 6 months of age, and blood test to be done by the government hospital or accredited laboratory. And disability certificate, earlier there was very ambiguity in giving the duration. Now it is fixed 3 years, and we hope it will be soon converted to 5 years. And since the disease is dynamic, progress is dynamic, so it should be rechecked or revisited after 3 years or 5 years, as the case may be. A disability certificate should be issued at district hospital, and again, a very good provision is that at fixed value, day and time should be there. So scoring notification issued on 4 January 2018. There is a long system, very exhaustive, and frankly, I apologize. This is quite big, and our thalassemia societies and even the hematologists who are working for thalassemia, they are not happy with this criteria. We want a simple one, an easy one, and there have been some meetings as well. We have submitted our recommendation, and we may. So these are documents which are required for certification, including tests like CBC, LFT, KFT, ferritin, BC, HIV, X-ray, ECG, etc., DEXA scan. For the 13 hospitals where in Delhi, where disability certificate is issued, and anybody can go to any hospital. Earlier, it was only from where they are getting. Now, irrespective whether where they are living in the Delhi or from where they are getting treatment, they can go to any of these. This is UDID, which is after the getting disability certificate, people have to apply for this. So, what are the benefits available to thalassemics? With the UDID card, treatment is available all over India. Once you show the UDID card, you will get blood filter medicine all over anywhere. If you have to, suppose today you are Delhi, you are going to Dehradun, Ahmedabad, you can get facilities over there. It's okay. Hello.
Yes, sir. Yes, sir. Yes, sir. Okay, sir.
Andhra Pradesh, their monthly pension is 500 per month. Assam, it is 1,000, and there is free parking at railway station, airport, and bus stop. In Chandigarh, pension is 1,000 who have score of 40 to 70%, and 2,000 having score more than 70%. Chhattisgarh, pension is 400 for score less than 75%, and 1,000 if the score is more than 75%. In Delhi, monthly pension is 2,500. There is a concessional bus pass at the rate of ₹15 only per month, against normal 1,000 per month for both AC and non-AC bus. There is a waiver of all fees, including examination fees, excluding admission fee in Delhi University. Haryana monthly pension is 2,500 for more than 18 years of age thalassemics, and 1,800 for less than 18 years. And it is free bus service available. Himachal pension is 1,300 for disability score more than 80%. Jammu and Kashmir 1,000, Punjab 1,500. Free bus service also available in Punjab. In Rajasthan, the pension is 700, it is 1,000. There was a subcommittee was formed by Ministry of Social Justice and Empowerment under the chairmanship of Dr. Sakti Prasad Das, Director S.V. Nirtar. Luckily, I was also a member of that committee. We have recommended some suggestion for under this ADIP scheme for the thalassemia patients to provide portable infusion pumps. I told you they cost around 30 to 50,000. So we have recommended 30,000, 35,000. Filters is a very much necessary for the patients, and sometimes it's not available. The hospitals can be provided by this under Addis Pain. It is 600 to 800 plus tax, 15 to 25 filters per annum are required by the patient. Sometimes by repeated they say blood transfusion, their this veins becomes very you can say spoiled. So at that time we have to give permanent inline, that is called intracatheter line or central venous implantable devices. So we have also recommended this device and surgery cost for these patients. Especially, I told you it is not easily available in government hospitals because of long queue, and privately it is very costly. At least some fund, say rupees 80,000, which is given to the under this scheme, so those who are needy can benefit it. Bone marrow transplantation, 12 lakh and around 250 transplants per annum. This is again by doing transplant, the government will receive a lot of money in the future blood transfusion and iron solution for the same patient. Here, I like to again highlight this, especially if there are any officials from the MOSJE, that the income ceiling, which is 20,000 per month, is very low, or say even BPL 1 lakh per month per year is very low. It should be increased to 5 to 8 lakh per annum so that more and more patients can be benefited. So what are the measures needed for rehabilitation of person with disabilities with thalassemia? So first and foremost here, what we got from CRC today is that public awareness to take preventive measures to create awareness in the general public to reduce the future burden and promote voluntary blood donation. Sensitization of the society, especially schools, to preclude discrimination. And since because of anemia, infection, hospital visits, they miss school and exams. Exam dates cannot be changed, but at least they can be given relaxation in attendance or extra time exams. And through though RPW Act in 2016, they were given reservation in higher education, but still employment is not there. Again, we have a request to MSJE. And besides free treatment, they have to incur financial burden because of this travel, or you can say even stay for 2-3 days while going outstation for blood transfusion and treatment. So these should also be, some support should be given to these patients as well. See, in Income Tax Act, there's a provision to income tax exemption for around rupees 75,000 per annum deduction, but it should be actual because their expenses are much more. So if this income ceiling is raised, I think more and more patient can be benefited. And again, I'm saying increase the ceiling to at least 5 lakhs, if not 8 lakhs. These are some cases you must have seen in the newspapers as well, where our society intervened and they were benefited, especially in the admission in many colleges and MBBS, Delhi University, and others. So thalassemics can live a normal life, normal adulthood, complete education, employment, happy marriage with normal children. And this has happened in the West and started happening in India. We all should pledge to make it happen for everyone. But this is only possible if all of us work together to save future generation from thalassemia and treat adequately those who are already there. Thank you very much.
Thank you, Dr. J. Sarora, sir, for your wonderful presentation today. And now it's a time for the discussion. Already we are running short of time. Participants, if you have any questions, you can ask to Dr. J. Sarora, sir, and you can type your questions in chat box also. Your questions will be answered.
Sorry for interruption because of some slides or the muting. There was some interruption in the presentation.
Yes. So we have to sorry for that. Yes.
Yes.
Indeed, it was a wonderful session, sir. We had a wonderful session today. And for participants, if you have any doubt, you can ask now.
Thank you. If there is no question, I'll like
Yes.
to give just repeat one message that is very important.
Yes, sir. You can go ahead, sir.
I think there are still, I see 234%, very good attendance. And I have request to all of you, those who are unmarried or married, still have not completed their family, they must go for thalassemia screening test. I'll advise you to go for this week only, because this moment it is in your heart. You are fresh with the knowledge. If because after say maybe month or so, 2 months or so, you may forget it. So my advice is, those who are here, around 235 people are there. Those who are unmarried or not completed family, they should go for thalassemia screening. And if it are they are exposed to or having an age of 50, 60 years, they can get their children for thalassemia carrier status. That's the first request. And second is, since their survival is blood transfusion, my humble request is, those who are between the 8 to 18 years to 65 years, having hemoglobin more than 12 gram, weight or 50 kg, please donate blood at least twice a year, so that not only thalassemia and other people can also look towards a normal, healthy, happy life.
Thank you, sir. Thanks for your message, sir. And we would be very happy to have this session today, and we look forward to have such a wonderful program in future within association with you, the team of Thalassemic Welfare Society. And also, we are going to conduct more awareness program. So we'll take from your message that we are plan to conduct more community outreach programs with the support of you people, and to reach for more people to create awareness about this thalassemia. And thank you, sir. Thanks a lot, sir. Next, I would like to invite my colleague and the fellow coordinator, Dr. Neeraj Misra, sir, to deliver the vote of thanks.
A few people have raised hands. If you, Lynette Fernandez, Muskan, some other.
Yes, sir. So any participants, those who raise your hand, do you have any doubt, you can ask. You can ask your doubts in Hindi and English.
Lynette Fernandez, let me call, okay.
Yes.
Lynette Fernandez, there? No. Okay, Muskan Singh. Muskan Singh, no. Rajani MK. Vaishali, I think they have gone. Vimal Trivedi, Shaista, Anupam Pal, Ratnavali Madam.
Sir, good afternoon, sir.
Good afternoon.
Sir, it was a nice session. All the session has been recorded. Can you share this recorded link so that joined later on can get benefited?
It's okay. My bad.
Hello.
I think it is recorded and it will be available on YouTube as well, your website.
Yes, we have a recorded link, the video we have. And if possible, if there is no any consent issues, we will be sharing that, no issues in that.
Sir, if you can share that, we will share this link to our fellow parents who are in thousands of them registered with us. So if you can share this recorded link, I will share with my fellow parents.
Sure, ma'am. Sure, ma'am. We will be sharing you.
Or you can send it to me. I'll send to all Thalas societies.
Yes, sir. Yes, sir. Yes,
Wonderful.
I'll send you through.
Wonderful, Arora.
Please send to me. I'll send to all Thalas societies.
Okay, sir. Okay, sir. I will send you, sir. I will send you.
Thank you, sir. Thank you very much.
Okay, thank you.
I think we can have our vote of thanks, Dr. Neeraj, sir.
So first and foremost, thank you so much, Dr. J.S. Arora, sir, for this wonderful presentation. Indeed, it was an honor to have you at our platform. And yes, all the participants will be immensely benefited. And as you have offered, if this can be shared with the Thalassemia Society, a lot more number of people can become aware of the problems of thalassemia and about the importance of testing. So thank you once again for taking out time from your busy schedule. And also I would like to thank our Director Officiating NIPID, Shri B.V. Ramkumar sir, for his constant support and motivation for all our programs, and to our Director Dr. Uma Shankar Mohanty sir who has been a source of inspiration and motivation for all of us, and who is always ready to allow us for any public awareness programs. And the most important, all participants who have participated in such huge numbers. Sir, let me tell you, our Google Meet capacity is 250, and today we have reached 249 participants. So almost the entire meeting was full, thanks to your knowledgeable lecture, sir. And thanks again to all the participants. At this junction, I would like to specially thank one of my teachers and mentors, Dr. Abhay Kumar Jaiswal, sir, and his students who are there for all the programs, and he has been a constant source of support and motivation and guides all his students to attend all these webinars. I am also thankful to my fellow colleague and coordinators of the program, Dr. Ganvil K. sir and Dr. Thamrai Silvan sir, and to all faculty members of CRC Davangiri who are helping us in organizing so many webinars from time to time. And thank you once again, everyone, and we hope to see you in all our future programs as well. Thank you so much.
Thank you, Dr. Neil, sir. So actually, we used to conduct the programs in association with other societies, also like Hemophilia Society, and also the Multiple Sclerosis Society, and also Muscular Dystrophy Association. And we are planning to conduct one more webinar, sir, in near future on government schemes and policies, and in association with all you, all the organizations, NGOs, for the benefit of the person with disabilities, sir. Just for your information, sir. So we'll let you know, sir.
Here to participate everywhere.
Yes, sir. Yes, sir. Thank you, sir. Thanks a lot. Thanks a lot for your time.
Thank you. Thank you, sir.
Thank you, sir. Thank you, Dr. Neeraj, sir, for joining with us, even on your holidays.
Thank you, sir. No, the numbers were good, and I think
Yes,
most
sir.
of them have already filled the feedback form.
Yes, sir. Yes, sir. I shared.
Thank you, sir.
It was a very informative webinar today.
Yeah, very, very nicely orated.
Yes, sir.
So, all right, sir.
So,
Bye. See you again.
Okay, sir. Bye, bye, bye. See you.
Bye.
See you. Take care. I request all the participants once again to fill the feedback form and submit, so that you will receive your e-certificates in your email. Thank you.
Thank you, sir.
You're most welcome. Okay.
Turban.